This is a very important topic. So I'm going to give in and out about this topic in detail. So any doubts you have, you can always post it in the chat box. We will be replying all those doubts at the end of the session. So before going to the session, let us discuss a brief anatomy of the gallbladder and the surrounding areas. Okay. So now I'm going to show you the anatomy of gallbladder and the surrounding things. So this is a liver. So you can see this is right hepatic duct. This is left hepatic duct. This is common hepatic duct. And it enters along with the main duct of pancreas known as Wirsung duct, major duct of Wirsung. It opens into the ampulla. This is a very important anatomy, basic anatomy. So right duct, left duct joined to form the common hepatic duct. So common hepatic duct is joined by cystic duct. This is a cystic duct and this is gallbladder. And it now forms common bile duct. So in an ultrasound, when you do an ultrasound for an adult patient, the normal diameter of common bile duct is 6 millimeters. This is a normal diameter of common bile duct. When the common bile duct is dilated, you should think of there is some obstruction in the distal end. So if the common bile duct is dilated in an ultrasound, you must always think of one thing, that is there is some obstruction in the distal part of the bile duct that is causing this common bile duct dilatation. So if you see, there is one another cause. Without any obstruction, the common bile duct can be dilated. Can you tell me what is it? This is one of the great confusion among surgeons when you are doing routine investigation. We get a finding known as a CBD of 14 millimeter. There is no stone, no stricture, no malignancy in the bile duct. We'll get a picture like this. And many times some radiologists will not be able to tell what is the exact diagnosis. And as a surgeon, you should know there is one disease known as choledochal cyst. Choledochal cyst is an abnormal dilatation of bile duct without any obstruction. There may not be a proper obstruction. It is a congenital anomaly. It is a congenital problem. It has been present from the childhood. The bile duct will be dilated without any obstruction. So you should always have this in your mind. So many times as general surgeons, even when I was doing general surgery, I doesn't have an idea about this choledochal cyst. And choledochal cyst is one of the important causes of non-obstructive dilatation of bile duct. So always have this in your mind. So you should always have this rare diagnosis in your mind. So, but anyhow, in practice, the common bile duct diameter is only 6 millimeters. If it is more than 6 millimeter, it should alert you that there is some pathology in the bile duct, and you should never go for a cholecystectomy directly without further evaluation. So now, for final MBBS level, there is a very important anatomy here at this focus. At this point, there is a very important anatomy you should not forget. All of you know, there is a triangle here. There is a confusion in this triangle anatomy. So this is a common hepatic artery coming. This is a common hepatic artery coming from celiac trunk. I'm not drawing the other anatomy. This is a common hepatic artery coming from celiac trunk. And this is gastroduodenal artery. This is right gastric artery. So these are the branches from common hepatic artery. After that, it becomes proper hepatic artery. It now divides into right hepatic artery and left hepatic artery, supplying the two lobes of liver. These are the two right and left hepatic arteries supplying the two lobes of liver. And from the right hepatic artery, you get a branch that is cystic artery. This is a cystic artery supplying the gallbladder from the right hepatic artery. So please don't forget, this is a triangle formed here now. This triangle now, it's formed, the yellow color picture I've made here is formed by cystic duct, common hepatic duct, and cystic artery. This triangle, cystic duct, this is a cystic duct, common hepatic duct, and cystic artery. This triangle is known as Kellogg's triangle. So many times the students are being confused by the various concepts in various books. Actually, this is the correct definition of Kellogg's triangle boundaries. So the correct boundary of Kellogg's triangle is cystic artery. So I used to tell as 3C: cystic artery, common hepatic duct, and the common hepatic duct and cystic duct. Okay, this is an actual triangle, Kellogg's triangle. So what you read in many books is this triangle. What is this triangle? Actually, this is a full triangle. What is this triangle? So this is a triangle. We call it as actually hepatocystic triangle. Okay, please don't get confused with this hepatocystic triangle. So now I am drawing the hepatocystic triangle. This is bounded by these parts. What are the parts bounding the hepatocystic triangle? It's a very common question for PG entrance exam also. You will get confused between the hepatocystic triangle and Kellogg's triangle boundary. There is nothing to get confused because hepatocystic, that itself says there is a boundary by liver. Hepato means this is a liver. Liver is one boundary, inferior surface of liver one boundary. Gallbladder with cystic duct is another boundary. This is a gallbladder with cystic duct is another boundary. Okay, please don't forget. Gallbladder with cystic duct is another boundary. Another boundary is common hepatic duct. So this is the boundary of hepatocystic triangle. There should be no confusion for final years and for PG aspirants related to this triangle. So Kellogg's triangle is a small triangle within the hepatocystic triangle. Kellogg's triangle is a small triangle within the hepatocystic triangle. No confusion in this. As laparoscopic surgeons, we are more concerned only about this Kellogg's triangle. We are least bothered about the hepatocystic triangle. We are very much worried about the Kellogg's triangle. Without defining a Kellogg's triangle, if you try to do laparoscopic cholecystectomy, you are going to cause more damage to the patient. So without Kellogg's triangle anatomy, I will never put a clip or never put a scissor anywhere. So I should have a clear anatomy of Kellogg's triangle. I'm drawing the Kellogg's triangle separately here. So Kellogg's triangle, this anatomy I should have before doing a cutting or clipping during surgery. The number one, cystic duct. This anatomy should be there. Cystic duct is as a one boundary, and cystic artery should be coming to the gallbladder as another boundary, and common hepatic duct as another boundary. So this is the anatomy I should have. In this triangle, there will be one node. I hope you know the name of the node. This node is known as Kellogg's node of Lund. So Kellogg's node of Lund. So this is a node inside the Kellogg's triangle. So this is the anatomy I should have clearly before putting a clip or cutting anything. Because please remember, many surgeons lose their practice by having some problem happening in this triangle. They do some damage in this triangle and the patient is going to be handicapped. In fact, we say it as handicapped for lifelong because of many complications that can happen. That is what we are going to discuss in this chapter. So Kellogg's triangle, to know, to go into this topic, you should know clear anatomy of this Kellogg's triangle. And while I am seeing this triangle, there is a view I should see from inferior. If this is a gallbladder, I will see with the camera from inferiorly. That view is known as critical view of Strasberg. This is a definite MCQ for PG aspirants. What is critical view of Strasberg? During laparoscopic cholecystectomy, with a 30-degree camera, please remember, with a 30-degree camera, you cannot see this critical view of Strasberg with a 0-degree camera. You can do it only with a 30-degree camera. From posterior to gallbladder, when I see from behind, I will see the picture like this. So I will see a picture like this. This is a cystic duct will be seen like this. And from posteriorly, I will see the cystic artery alone entering like this. So in a critical view of Strasberg, there should be only two structures should enter the gallbladder. That is known as critical view of Strasberg. So when I see by laparoscopy with a 30-degree camera, I should see only two structures that will enter the gallbladder. If there are more than two structures entering and you are trying to put a clip, you are in danger. Please remember, patient is not in danger. You are in danger. You are going to face a lot of medical legal issues and various problems. So if there is one duct and one artery is entering, there is nothing to worry. To one artery and one duct is entering, you can put a clip in this duct, you can put a clip in this artery, and we can cut and remove the gallbladder. After that, there is no issue. So after that, there is no issue. So if there are more than two structures entering, let me tell you what happens. See, understand this picture. If there are more than two structures entering, I am drawing the picture now of more than two structures entering the gallbladder. See the picture. If I am seeing a critical view of Strasberg like this, if there are more than two structures entering, one structure of tube, two structure of tube, and three is a structure. What do you think this is? If I'm trying to clamp, if I put a clamp here, and if I put a clip here, if I put a clip here, and if I put a clip here, and if I put a clip here, I am in danger now. What happened? What is actually the structure? Due to excessive traction, please remember, this is nothing but a common bile duct, just 6 millimeter common bile duct. There is no cystic duct. Sometimes there will be very small cystic duct, or cystic duct may be absent also. I'll show you the anomalies. The cystic duct may be absent also. Such condition, what happens? There will be no cystic duct, the junction will not be typically seen, and you will be clamping a CBD, thinking it as a, please remember, you will be clamping a CBD, thinking it as a cystic duct. So the most common error are the most common reason for bile duct injury is misperception. Please remember, this is a very important thing, especially in a laparoscopy. Misperception of CBD as cystic duct. Very, very, very dangerous. Misperception of CBD as cystic duct. So misperception of CBD as cystic duct is a very important problem. You should not forget. This is a very important thing you should never forget. So misperception of CBD as cystic duct is a very dangerous issue. Please don't forget this. So this is the reason for most of the bile duct injuries. This is the reason for most of the bile duct injuries. Why it is getting injured is there is a misperception of CBD as cystic duct. So this is very important anatomy. You should not forget. I'll show you why we should be very careful with this, because there are many surgeons getting into trouble because of clipping as a CBD or laterally injuring the CBD. There are many reasons for getting into trouble post-operatively. So laparoscopic cholecystectomy, you should be very careful. You should know all the anomalies. There are enormous anomalies around the gallbladder and cystic duct. You should be knowing them, and you should be playing very safely in a laparoscopic cholecystectomy. Let me show you some essential things you should not forget for your exams. So this is a picture showing you hepatocystic triangle and Kellogg's triangle. So we always very much, as a general surgeons, many times will be very much worried about the duct. But gastrointestinal surgeons, we will be more worried about more than the duct, because we will be very careful, we will not injure the CBD. But we will be more worried about this right hepatic artery, which may enter into the Kellogg's triangle. What is it known as? What is that anomaly known as? So this is a picture directly from Bailey and Love. You can see this is a normal triangle of Kellogg's. This is a normal triangle of Kellogg's. You can see the cystic artery entering into the gallbladder. In the second picture, you can see it looks like cystic artery. It may appear like cystic artery, but it is not cystic artery. It is a tortuous course of right hepatic artery. Very, very dangerous. Right hepatic artery is having a tortuous course inside and entering the liver like this. So it is right hepatic artery is entering like a tortuous course. That is known as Moynihan's hump or caterpillar's turns. So that is known as Moynihan's hump or caterpillar's turn. This is a very important anomaly. We again have a misperception. Again, the problem in laparoscopy, most of the injuries are due to misperception. I will think this is cystic artery and I will put a clip in the right hepatic artery. What will happen? If I put a clip in the right hepatic artery, very, very dangerous. Very, very dangerous. If I clip the right hepatic artery, what will happen? Will the liver go for necrosis? Not. Liver is not going to have a necrosis. So please remember, I will tell you now what happens when I put a clip in the right hepatic artery. That is not going to present now. Patient will go home. He will be having no trouble. He will go home because 80% of the blood flow to the liver is from portal vein. Even if I put a clip to the right hepatic artery, patient is not going to die now. He is not going to die now. There are many cases going up without realizing this. So this is a right hepatic artery. This is left hepatic artery. This is proper hepatic artery. This is a hepatic artery. So now why should I very much worry if I clip this right hepatic artery? I'm not cutting. I just clipped like this on two sides and I have cut the right hepatic artery. The right lobe will not go for necrosis or gangrene. Nothing will happen to the right lobe because the 80% of the blood flow to the right lobe of liver is from portal vein only. So therefore the liver will not get damaged. So if you cut the portal vein, liver will be gone for gangrene. But if you cut the right hepatic artery, there will be not much problem. But the problem is here. The problem starts here. This is a bile duct. Common bile duct. Please remember, common bile duct gets its blood supply exclusively from right hepatic artery like this. A descending branch from above. And another branch is from, this is a gastroduodenal artery. This is gastroduodenal artery. There is a branch running like this from below upwards. So from gastroduodenal artery below and right hepatic artery above, there is branches running at lateral wall of the lateral and medial wall of the common hepatic duct. We have blood flow like this. So therefore, what will happen in days, as days goes on, they can develop stricture. They can develop bile duct stricture. That can develop a bile duct stricture in future. Many times the right hepatic artery injuries are missed during surgery, and many times patient comes to us after 2 years or 3 years with a bile duct stricture. So we will be thinking many times as what we think is, we will be thinking that surgeon has done a laparoscopic cholecystectomy and he has done a bile duct clipping at the time of surgery. That is the reason for bile duct stricture. This is what many surgeons think, but it is not due to that. It is not due to that. It is because of a right hepatic artery which is being clipped without your own knowledge during the previous surgery is a reason for this bile duct stricture. So please don't forget, this is very important. Moynihan's hum.